First of all, I want to congratulate the organizing committee for the great success of this amazing event. And I also want to show my gratitude to Dr. Calvin John to organize this Rising Star section. And I'm really happy and honored to have the chance to share with you today. Today I will introduce the high pull paddle gear technique, so-called HPPG. We can ensure the whole maxillary dentition by one main paddle screw and two little buttons of the lateral incisors. It is very efficient in correcting gum smile. We have published a case report in JCO by using these mechanics and get the cover story in this July. And let me introduce my perfect pitch team. And this is our team leader. It's also my mentor, Dr. Leslie Chen. And this is Xin Hui Wong. And this is Dr. Ronsi from Thailand. If you did not miss Dr. Wong's lecture yesterday, she mentioned the importance how to achieve the perfect pitch in our patients. And what is perfect pitch? The common complaints from the patients, including the profile, the tooth show, the smile arc, they are all related to the AP and vertical correction. And the intersection is called the pitch. So the perfect pitch is to achieve a better profile and also with a good tooth show. And we hold the perfect pitch courses in Taiwan to share our perspectives and techniques since 2022. And in last year, August, we also hold the perfect pitch in Bangkok to share with the Thai doctors. And also I want to thank the Thai doctors because they gave us so many feedback and they shared their good results in the patients after a short period of time. So you all can try to learn these mechanics from now. I think the art of AP and vertical control is like making dumplings. We want to fully wrap the dumplings, but not to remove too much meat. So we have to control the pitch instead of retraction only. And how do we achieve perfect pitch? You can look at this paper called the maxillary incisor position and IP space planning. We should do the planning not only initially, but also every appointment when the patient comes back. And we have to check if we need any modifications. And there are 5 steps. The first is the upper incisor position. The second is to see if we need the upper occlusal plane change, and then we decide the upper molar position. After the patient has good upper tooth show, then we check if he or she had a soft tissue strain, and if he is suitable for mandible counterclockwise rotation. And finally, we decide if we need lower total intrusion. You can see that the blue line is the upper teeth, and the yellow line is the lower teeth. We know that if we want to reduce the vertical dimension in the open bite case, we have to focus on the posterior intrusion. We know that if we intrude more than 1 millimeter, we can close 3 millimeter open bite. So the amount of anterior open bite closure is larger than the amount of posterior teeth intrusion. And how about if we want to reduce the vertical dimension in a normal bite patient? We need to intrude both anterior and posterior teeth. So the amount of anterior intrusion should also be larger than the amount of posterior intrusion. Then we can maintain the occlusion. This is the common problem we can see in many case reports. You can see that in this case, it is not an anterior open bite initially. But if we focus the intrusion on the posterior teeth, the intrusion force is behind the CR of upper dentition. So the upper posterior will intrude more than upper anterior, and this will cause posterior open bite. And finally, you need to settle occlusion by posterior elastics. So you lost all of the vertical control you got. And after we have the idea who we need to intrude, we can decide the optimal force direction. If you choose the right force and let the teeth go toward the same direction during the whole treatment progress, it will shorten your treatment time a lot. For example, if there's an anterior open bite without gummy smile, we focus the intrusion on the posterior teeth. So the intrusion force must be backward of the CR. If the patient has anterior open bite and gummy smile, we have to intrude both anterior and posterior, and probably the same amount. In the case that the patient has more bite or debite and has gummy smile, we have to intrude upper anterior more than upper posterior. So the force must be in front of the CR. And I mentioned that if we want to intrude in anterior more than the posterior, the force must be in front of the CR. And how do we create this force vector? If you place a buccal screw at this low position, you will create clockwise rotation of the upper occlusal plane. Upper incisor will extrude and lead to gummy smile, and it will also cause anterior interference, and mandible will have backward rotation. It is also the major cause of why upper anterior teeth is lingual tipping. But in the lower lingual case, when you want to increase the tooth show, this mechanism is very suitable. How can we minimize the clockwise rotation from the buccal screw? We can try to put the screw really high enough to create more vertical force. But in the early stage of space closure, there is a large distance from the force to the CR of anterior segment. So sometimes we need to add some auto torque on the wire. But sometimes we still cannot put the buccal screw high enough. So this is the dual screw method proposed by the Lindsay group. If you add another screw in front of the CR of maxillary arch, then you can achieve intrusion and counterclockwise rotation of the upper arch. But I think you really need very good skills to prevent any screw contact with the root. The another common method is to add intrusion force from the anterior screw to try to let the equivalent force near the CR of anterior segment. The common position of the anterior screw is between the centrals or between the lateral and canines. But I have to remind you, when you put between the central, you cannot correct the canting. But if you put the mini screw between the lateral and canine, you can see that after retraction, the screw is not between the lateral and the canine. So sometimes it will be a problem when you have still a lot of space to close. You must not put the screw in the very early stage of space closure. And if you use the HPPG technique, the screw is 100% accidental, and you will have more intrusion without the screw contact. It is named after the hypoc gear because of the same force direction, but we do not have the patient's compliance. So you have a wider playground to place the mini screws in the mid-palatal area called the T-zone. I think this is a game changer for me to make my daily practice easier. I have tried more than 500 cases with these mechanics, and the outcome is pretty predictable. The indications included gummy smile, occlusal plane canting, hyperdivergent faces, and instrument cases. And how can we transmit the intrusive distalization force to the whole dentition? When the lateral incisor receives the force from HPPG, the wire will be lifted upward and backward if the wire is rigid, and the whole dentition can feel the force. When you use a full-size wire, the wire is more difficult to move through the tube, and the friction will help to distalize the terminal molar. So the total arch movement is more efficient if you use a full-size rigid wire. But we still have to face the bracket wire play when we retract the lateral incisor by the palatal screw. The lateral incisor will rotate around the wire. When we use a 70 by 25 steady stir in the 18 slot, we have 4.2 degrees of play. So the lateral incisor will rotate 4.2 degrees then stop. But if we use a 70 by 25 steady stir in the 22 slot, you will have 15.1 degrees of play. So it will be very easy to see root prominence and washboard effect more easier in the 22 slot when using HPPG technique. And it is like when we sit in the free fall facility. If we want to fly high together, the machine has to be rigid and everybody's seatbelt fastened. Nobody can move inside the chair, so that is more safe. If the system is not rigid, it will be like a jumping rope. Only the anterior teeth can feel the force. The whole dentition cannot be easy to be intruded. Before we decide where to put the HPPG, we have to know that the target CR is moving in the extraction cases. In the initial stage of space closure, because the extraction space is still large, the wire is not rigid at the extraction site. So the target CR is at the anterior segment. When the space closes, the target CR will move to the whole arch dentition. So the reciprocal space closure and let the space smaller is beneficial for total intrusion because the system will be rigid earlier and the intrusion of posterior teeth will be more efficient. And also, if we want counterclockwise rotation, let the target CR move to the whole dentition earlier, backward, and the force will be easier to be in front of the CR. And the theory can be explained in this FEN study. This study divided to the two groups. The upper is the low traction of the mini screw, and the lower is the high traction of the mini screw. We know that when the screw is low position, we will have more clockwise rotation. But in the early stage of the space closure, even in the high mini screw traction group, the upper anterior will also intrude, but it's lesser than the low traction group. When the space almost closes, the target CR will move backward to the whole dentition, and the situation becomes different. In the low traction group, the occlusal plane continues clockwise rotation, but in the high traction group, it becomes counterclockwise rotation. And this is the key why HPPG can get faster counterclockwise rotation than multiple screw, because we can have reciprocal space closure earlier, let the force be in front of the CR earlier, which you cannot do in the buccal screw. And where to put the HPPG? Because if we only use one screw, the mini screw position is more important than we use the multiple screws. We choose anterior HPPG when the case has upright upper incisors or narrow alveolar housing, because the force has the smallest distance to the CR of the anterior segment, so the torque will be controlled better, and upper occlusal plane will have more counterclockwise rotation. It is indicated in the large gummy smile when we want more anterior intrusion. And when do we use posterior HPPG? Because the distance from the force is larger than anterior HPPG. So upper incisor will have more nickel tipping. It is indicated in the case we need more upper incisor retraction. In the non-extraction distalization case or upper 5 extraction case, because the target CR is more backward to the upper 4 extraction, so we do not have to shorten the distance from the force to the CR2 so much. And also when we use posterior HPPG, the posterior teeth will intrude more. And if the case that has a very large anterior open bite, we can combine TPA for more posterior intrusion. And this is a common question some doctors worry about. If upper incisors will be very easy to retropline because of using palatal screw. Actually, the teeth, they cannot recognize the force is from the buccal screw or from the palatal screw. They only can recognize the distance from the force to the CR. So if you are not worried about the low position buccal screw, which the force is the farthest from, the distance is farthest from the CR, why should you worry about the anterior HPPG? Because the force, the distance is the nearest to the anterior segment CR. And what's the difference with HPPG and multiple screw? Even though that we have anterior screw, we can control the proportion of intrusion force. But when we can control, that means that we need to control, and we will miscontrol. And sometimes you want the space to close faster, so you accidentally give a larger retraction force. And next appointment, you found out that the torque is lost and gummy smile is more severe, so you increase the intrusion force. So in every appointment, the force is not consistent, and you always cannot loss anchorage in this kind of mechanics. So it's more easily to have over retraction. And I think it's more technique sensitive to me because it's more easy for me to control the same ideal force from HPPG. And this is like a shooting competition. You need to get more points in every appointment. If you are really a busy orthodontist, you have to see lots of patients a day. You have to really need to reduce the side effects you made, or else you will be even easier in the future. So there are lots of benefits of HPPG mechanics. The patient will be not so frightened because we use less mini screws. And compared to anterior screw, anterior screw will restrict the retraction, so we can have more efficient retraction with intrusion by using HPPG. And we have a zero probability of root contact, so we have more predictable posterior teeth intrusion. And you are not so stressful about the screw loosening anymore. Because the force is on the lateral incisors instead of the buccal segments, so you have better control of the arch form and transfers. You will have less palatal cups hanging down, so you do not have to put a TPA. You can correct the occlusal pancaking by unilateral force of the HPPG. And also you have the patient has a less oscillation compared with buccal screw. We do not have to control the multiple force. The force direction is more accurate, and the force is more near the CR of anterior segment. We can do reciprocal space closure, so we can move the CR backward earlier. You have more earlier rigid system. You have a shorter treatment time and less over-retraction possibility. There are many problems of upper incisor over-retraction, as Richard Chen just emphasized in his lecture. First, the patient will complain about the tooth show. And if the upper incisor root already hit the palatal-cortical bone or the incisor canal, sometimes it will have a big root distortion if you still continue on to hit the palatal root or intrude along the palatal cortical. And if there's sometimes we have some total intrusion, but we have over-retraction, you can see that the blue line and the red line, the incisors are intruded in the same level. Because the upper occlusal plane is an angle, so you have different clearance of unilateral counterclockwise rotation. We also can take advantage on reducing the wedging effect in high-angle patients from the intrusion and the protraction of posterior teeth. But you always have to remember, if there's an anterior interference, the medial counterclockwise rotation will not happen after de-wedging. And there are also some things you need to remember when using HPPG technique. When you have a deep bite or anterior interference, the HPPG mechanics will not work because the upper anterior teeth cannot be intruded without retraction. So you can raise the bite at the lower posterior if the lower anterior teeth will bite the button. So you can get some clearance for lower curve leveling. And if there's washboard effect or unfavorable torque, it means that the roots are not in the alveolar housing. You have to stop the HPPG mechanics after the root is back into the housing. It is like parking the car. We have to park the car in the right direction. You do not want to park your car like this, and you will damage your car. So please do not intrude with the wrong torque or not in the alveolar housing. And some doctors want to combine the buccal screw for anchorage with HPPG. Please do not do that. You will decrease the intrusion effect. Because the equivalent force will become lower and unpredictable again. In some rare cases, the palatal vault is so shallow, so you cannot let the force be in front of the CR. So in these cases, the palatal screw will not provide high pull force enough, and you still need to add another intrusion force. And do not be too excited about this mechanics and use it in every case. And you should not over-intrude the upper anterior teeth. Always check in the final appointments that upper incisor show at rest must be at least 2 millimeters. Sometimes if you over-intrude, the smile arc is too flat. You can rebuild the smile arc with anterior elastics. In the really hyperdivergent case with severe mental strain, if the upper tooth show is ideal, you need to do the lower total intrusion. Always remember the MIP-based planning. In the final part, I will show 2 case reports we published by the Perfect Pitch team. This young male, he complained about protrusion from his mouth, and he has a long face with mental strain. This is his initial occlusion, the initial panel X-ray. This is a typical bimaxillary protrusion case. His vertical problem included gummy smile, mental strain, and a long lower facial height. So we need to do the double arch total intrusion. This case is very protrusive. In the old days, I will try my best for maximal retraction. But with the idea of perfect pitch, now I pay more attention to the vertical improvement. In this case, upper 4 and lower 5 were retracted. I put the anterior HPPG between the 3 and 4 after the root gate area for more upper incisor intrusion. In the lower arch, I put the mini screw between 4 and 6, very low position to get more vertical And this is the comparison. The protrusion was improved. The gummy smile was improved also with a good tooth show. The metallic strength was improved and a better soft tissue chin. Do you think that the profile change is not enough because we didn't do maximal retraction? This is his final conclusion. And from the self superimposition, we can draw a line of the upper and lower occlusal plane. And both upper and lower, anterior and posterior, they are all intruded above the occlusal plane. The mandible has a significant counterclockwise rotation. The final panel showed no obvious root resorption after massive intrusion. I think this is the key that we intrude along the housing in the cancellous bone. Even though this case is very protrusive, we did reciprocal space closure combined with double arch intrusion. But if I want to remind you, if you over-retract it, you get less chance to rotate the mandible. And when you rotate the mandible more, you will have the more chance to change the chin point in the E-line, and the effect to the profile is bigger than the lip response from retraction. So then you do not have to retract so much, and you will preserve the tooth show. And you can download this paper in JCO in this July, and it is freely accessible. The second case is a retreatment case. This young lady complained about protrusion gummy smile after the previous orthodontic treatment. She had a long face, protruding chin, and a metallic strain. She had already 4 premolars extracted. This is her initial panel X-ray. Her vertical problem included gummy smile, metallic strain, and a long lower facial height. So we need to do the double arch intrusive visualization. Because this case already had premolar space closed after the first treatment, so the target CR is at the CR of whole dentition. And I want more distalization, but I still need some counterclockwise rotation. So the HPPG is more posterior than the previous case. In non-extrusion case, I usually do not put the HPPG too anterior to cause anterior open bite by too much counterclockwise rotation. And in the lower arch, I place the screw between the 4 and 6, very low position for double arch intrusive visualization. And this is the comparison. The protrusion was improved. The gummy smile was also improved. Her metallic strength was disappeared. She had a more harmonious profile and a better soft tissue chin. And this is the final conclusion. And all of the teeth are intruded. Mandible counterclockwise rotation after double arch intrusive visualization. The upper incisor torque is also very good maintained. And I think you can feel the power of the intrusive visualization of HPPG in this case. You can see that an upper molar can bodily distalize this far. So this is why I don't worry about the anchorage loss in extraction case at all. It is very easy to distalize the whole dentition by HPPG after the space is closed. And there's no obvious upper incisor root resorption after the massive intrusion. And it is also freely accessible, so you can also download this paper in APOC Trends in Orthodontics. And if you're interested in how to get a perfect pitch, I invite you to visit our Perfect Pitch Wonderland again in the future. We're holding a 3-day course in 2026 spring in Taiwan. And we will go through all the basic knowledge you need to know, more detailed techniques and hands-on. If you want to join us, you can link to the registration website by this QR code. And I hope you can get some new ideas and information after my presentation. Thank you very much for your kind attention.